Podcast 1 of the Abdomen series. Surface anatomy of the abdomen and the anterolateral abdominal wall. This is the first podcast in the Abdomen series and is going to detail the surface anatomy of the abdomen and also describe the musculature, movements and function of the anterolateral abdominal wall. So let's start by looking at the surface anatomy of the abdomen, and then we'll look at the anterolateral abdominal wall towards the end of the podcast. So the anterior surface of the abdomen extends from the xiphoid process and costal cartilages superiorly to the pubic bones of the pelvis inferiorly, and is characterized by numerous features including the umbilicus, the linea alba and the linea semilunaris. The umbilicus is usually located at the level of the intervertebral disc between the third and fourth lumbar vertebra, but this can vary depending on the amount of subcutaneous fat present. Extending above and below the umbilicus is the linea alba, a fibrous groove that lies in the midline and separates the two rectus abdominis or six-pack muscles. Lying on the lateral border of the rectus abdominis muscles is the linea semilunaris, and this separates these muscles from the remaining muscles that form the anterolateral abdominal wall. Now, also found on the anterior surface of the abdomen are a series of bony structures. The pubic symphysis, which unites the two pubic bones, can be palpated at the inferior limit of the linea alba, and lateral from this point, the two anterior superior iliac spines are located. These are found on the anterior limit of the iliac crest. These anterior superior iliac spines can be conveniently abbreviated to ASIS, A-S-I-S, and these provide a useful landmark for locating the appendix. So to locate the appendix, a diagonal line running between the umbilicus and the ASIS on the right-hand side is imagined, and the apex is located deep to the anterior wall, approximately a third of the way from the ASIS. This point is referred to as McBurney's point. For clinical practice, the surface of the abdomen can be divided into 9 regions by 2 horizontal planes and 2 vertical planes. These 2 vertical planes are the midclavicular lines, which pass between the midpoint of the clavicle superiorly and the middle of the inguinal ligament inferiorly. This separates the abdomen into 3 vertical regions. These are then separated into 9 regions by the horizontal transpyloric plane, which extends across the abdomen at the level of the first lumbar vertebra, and is also at the level of the stomach's pylorus. Inferiorly, there is the horizontal transtubercular plane, and this extends across the abdomen at the level of the iliac tubercles, which are located in line with the 5th lumbar vertebra. So these 4 planes are used to separate the abdomen into 9 regions. Superiorly, there are the right and left hypochondriac regions, which are separated in the midline by the epigastric region. Below these are the right and left lumbar regions, and these are separated by the umbilical region. And finally, most inferiorly, are the right and left iliac regions, and these are separated by the hypogastric or suprapubic region. A good understanding of these regions, and specifically the organs that lie deep to them, is important during auscultation, percussion and palpation of the anterior wall of the abdomen. So in the right hypochondrial region, there is the liver, gallbladder, adrenal gland and the hepatic flexure of the colon. In the left hypochondrial region is the stomach, the spleen and the other adrenal gland. There's also the splenic flexure of the colon. Centrally, in the epigastric region, is the left part of the liver, the transverse colon, the pylorus of the stomach, and the first part of the duodenum. If we move inferiorly, in the right lumbar region is the right kidney and the ascending part of the colon. In the left lumbar region is the left kidney, there's also the descending colon, and centrally in the umbilical region is the remaining parts of the duodenum and also the pancreas. If we move inferiorly again, in the right iliac region there's the cecum and the appendix. In the left iliac region there's the sigmoid colon, and more centrally within the hypergastric or the suprapubic region there's the bladder and the uterus. Throughout this description, you'd have probably noticed that I haven't mentioned the small intestines during this description. Well, the small intestine is the most mobile and variably located organ in the abdomen, and this can be found in any of the 9 regions, but is usually located in the inferior 6. As an alternative to the 9 regions described, and for more general description, the abdomen can also be divided into 4 quadrants: the right upper, the left upper, and the 2 right and left lower quadrants. These quadrants are formed by the vertical median plane and the transumbilical plane, which traverses the umbilicus. So in this second part of the podcast, let's turn to the musculature of the anterolateral abdominal wall. The anterolateral abdominal wall is a flat, muscular aponeurotic wall which moves the trunk and protects and compresses the abdominal viscera. It extends from the thoracic cage superiorly and to the pelvis inferiorly, and is split in the midline by the linea alba. Either side of the linea alba are the 5 bilaterally paired muscles: external oblique, internal oblique, transverse abdominis, rectus abdominis, and pyramidalis. Deep to this relatively thin but strong and tough layer of muscles is the transversalis fascia, and then we have the peritoneum. So let's detail these muscles. External oblique is the largest of these anterolateral muscles and extends from the anterior surfaces of the 5th to 12th ribs and inserts on the linea alba and anterior half of the iliac crest. The fibres of external oblique run downwards and forwards, and at the level of the midclavicular line, these fibres are replaced by the external oblique aponeurosis. The aponeuroses of the 2 external oblique muscles merge at the linea alba and contribute to the rectus sheath. Directly posterior to external oblique is internal oblique, and this muscle originates from the thoracolumbar fascia posteriorly, the anterior half of the iliac crest, and the lateral half of the inguinal ligament. It fans out anteromedially to insert onto the 10th to 12th ribs, the linea alba, and the pubic bone. The majority of these fibres run perpendicular to that of external oblique, and as it merges with the aponeurosis of external oblique, it contributes to the rectus sheath. The third and deepest of these more laterally positioned anterolateral abdominal wall muscles is transversus abdominis. This muscle extends from the posterior surfaces of the 7th to 12th ribs, the thoracolumbar fascia, the iliac crest, and the lateral third of the inguinal ligament. Its fibres run transversely towards the pubic bone and the linea alba, where it merges with the aponeuroses of internal oblique and also contributes to the rectus sheath. The final 2 muscles of the anterolateral abdominal wall are vertically orientated and are positioned either side of the linea alba. These are rectus abdominis and pyramidalis. Rectus abdominis is a strap-like muscle that extends from the pubic symphysis and pubic crest inferiorly to the xiphoid process and the costal cartilages of the 5th to 7th ribs superiorly. This paired muscle is separated in the midline by the linea alba, and the linea semilunaris marks its lateral border. Surrounding the rectus muscle is the rectus sheath, and this is formed by the 3 pairs of aponeuroses that extend from the external oblique, internal oblique, and transverse abdominis muscles. As these aponeuroses extend medially, at the lateral border of rectus abdominis muscle, the aponeurosis of external oblique lies anterior. The aponeurosis of internal oblique splits into 2 layers, or lamina, with one extending anteriorly and the other posteriorly. And then finally the aponeurosis of transversus abdominis extends posteriorly behind rectus abdominis. This arrangement means there are 2 layers of aponeurosis anterior to rectus abdominis and 2 layers posterior. Lying most posteriorly to the rectus sheath and separating it from the peritoneum is the transversalis fascia, and this collection of aponeuroses that are surrounding rectus abdominis is the rectus sheath. However, this arrangement of aponeuroses is not consistent for all of the rectus sheath. Starting at approximately a third of the way down from the umbilicus to the pubic symphysis, the rectus muscle pierces the posterior layers, and this means that only the transversalis fascia lies between the rectus muscle and the peritoneum. At this point, all 3 aponeuroses now lie anterior to rectus muscle, and this region is demarcated by a crescent-shaped line known as the arcuate line. The final muscle I want to mention is pyramidalis. This is a small triangular muscle that is present in approximately 80% of the population. It sits in the inferior aspect of the rectus sheath, anterior to the rectus muscle, and extends from the pubis to the linea alba. All of the muscles in the anterolateral wall of the abdomen are supplied by the thoraco-abdominal nerves, and these are the anterior rami of the inferior 6 thoracic spinal nerves, so T7 to T12. These nerves emerge from the costal groove of the ribs to run in the neurovascular plane, which is located between the internal oblique and transversus abdominis muscles. Also running within this plane are the paired superior and inferior epigastric arteries. The superior epigastric arteries are a direct continuation of the internal thoracic, whilst the inferior epigastric arteries are a branch from the external iliac arteries. These arteries supply the musculature of the anterolateral abdominal wall, and under certain pathological conditions, like coarctation of the aorta, can anastomose to form an important collateral circulation. So as I briefly mentioned earlier, the anterolateral muscles of the abdominal wall are important for numerous reasons. Contraction of these muscles will cause various movements, like flexion of the trunk with rectus abdominis, but most of the anterolateral abdominal wall muscles work as a single unit. For example, due to the direction of the right external oblique fibres and the left internal oblique fibres, contraction of these muscles can move the right shoulder towards the left hip. Alongside the movements achieved by these muscles, the anterolateral abdominal wall also has an important role in protecting the abdominal viscera, and functionally it is involved in changing the intra-abdominal pressure. Contraction will increase this pressure, and this is required for micturition, defecation, vomiting, and parturition. So in this podcast, I've described the location of the abdominal viscera in relation to the 9 regions of the abdominal cavity, and also highlighted some landmarks on the anterior surface of the abdomen. And finally, I detailed the musculature of the anterolateral abdominal wall. In the next podcast, number 2, I'll enter the abdominal cavity and describe the peritoneum.